the first lecture, which is titled Ablation, an Effective Interventional Armamentarium, which is a pretty catchy title. So,
good morning,
go ahead.
everyone, and thanks for the invitation by Smart Health Tower to present in today's activity. Fortunately or unfortunately, they've given me the topic of ablation to talk about in general, and it's a topic that's too broad to cover and definitely beyond the scope of this presentation. And so I'll try to be as succinct as possible. Also, I would like to apologize so generally speaking, as a historic overview, we have over the last 2 decades increasing applicability of ablation, be it thermal, be it non-thermal, and in different tissues, be it in the liver, lung, bones, and other tissues. And evidence has proven the benefit for liver, bone, lung, and renal tumors. Clearly, like anything else, they come with the shortcomings, for example, tumor size. So they have a very good evidence for tumors up to 3 centimeter. Above 3 centimeter, you have a bit increasing local recurrence with time. However, we need to understand this fact as well. With better tools, better ablation capabilities, that we will be able, and we are able at the moment, to cover increased size of the tumors. Clearly, other shortcomings will be lack of availability of the tool or the skill set in the region. It's not available everywhere in the world. And also, what we were saying as well. So that leads us to the other fact that we need to train more personnel to be able to use these tools. So as an overview for different types of ablation, clearly we have a chemical ablation, we have thermal, and we have external energy. Chemical, such as alcohol or acetic acid, we have thermal, so be it freezing, which is like a cryoablation. Thermal, we have microwave and radiofrequency. We have laser, we have electroporation, and we have external energy delivery, such as in case of HIFU or histotripsy. So these are different types of ablation. You can use more than one type for certain tissue or for certain tumors, such as in the liver. We can use IRE, or we can use microwave, or we can use radiofrequency. Also, we can use cryoablation. Previously, for smaller lesion, we used to use alcohol. And so on and so forth. So this is just an umbrella tool that we divide the ablation into categories. So just brief talk about microwave ablation. Microwave ablation is it's an application of energy that's between 300 and 3000 megahertz. It works by inducing coagulative necrosis of the tissue or of the tumor. It has few major benefits that's famous for microwave ablation. First of all, we have less heat sink effect. So when you have a tumor next to a blood vessel, so the effect of the heat sink will be much less for microwave ablation as opposed to radiofrequency ablation. It has also a larger ablation zone. By far, it has a larger ablation zone. And clearly, it needs less time to produce that ablation zone compared to other modalities or other tools such as cryoablation or radiofrequency ablation. And this less ablation time clearly is useful because, for example, you're dealing with multiple tumors. You're dealing with 3 or 4 tumors in the liver. And so requiring less time means less sedation or less GA time for the patient, and so on. And also we are able to produce with less time large ablation zone. So that's why for microwave ablation we are talking about treating tumors of 5 centimeter or even slightly larger. Second is a radiofrequency ablation. Radiofrequency ablation, it uses the energy in between 375 to 500 kilohertz. And again, it's a type of thermal energy as we know, and it uses rapidly alternating radiofrequency current to induce frictional heat around the probe that's placed in the tissue. So you put a probe or few probes in a certain area in a tissue or in a lesion, that will rapidly alternate radiofrequency current to that region, and this will induce heat, and by that will result in cell death, again by the same principle of microwave ablation, which is coagulation necrosis. And then we come to the third one, which is cryoablation. Cryoablation is the same principle of thermal energy, but it's different in the way that it uses freezing temperature or a freeze and thaw cycle effect to produce ischemic damage. So what we do, we introduce the probe or the antenna or the tool to the required region, and then start the ablation process by this method, and then it will reach around -40, -50 degrees Celsius, and to produce an ice ball like around in the tumor and around the tumor. Sometimes continuous freezing, sometimes with freezing and thawing effect, and this will result in ischemic damage to the arteries and vein in the region. And this is the basic principle of cryoablation. So, as I said, it's a very broad topic. It's beyond the scope of this presentation to talk about all different types of ablation methods. But clearly, I talked about microwave radiofrequency and cryoablation being relatively the most common types of ablation that we use nowadays in the world. And the application is important as well. We use it a lot for liver tumors, be it primary, such as HCC, or secondary, as in metastases. We are using it more and more in lung tumors. We're starting to use it in pancreatic tumors, and also it's been a very common practice to use it for bone tumors, such as in case of osteoid osteoma and osteoblastoma. Also, prostatic tumors is getting more common, and the recent advance and a lot of talk about thyroid ablation also, and also other soft tissue tumors. We are using it in large fibroids, for example, in the uterus. So what we have in the liver, which I personally do a lot, and I find it very effective, both by anecdotal experience of myself and my colleagues, clearly, as well as by evidence. There are large number of randomized controlled trials comparing radiofrequency ablation or microwave ablation with surgery, also ablation versus best medical treatment. They clearly show benefits. So for liver, as I said, we using it for primary liver tumors such as HCC, which can be used as an alternative to surgery, or when the patient is not a surgical candidate. Clearly, historically, the gold standard for HCC has been surgical, as in liver transplantation, if it's within the setting of cirrhosis, if the patient is a candidate for liver transplantation. However, a lot of these patients are not candidate for liver transplantation. And we can also use them as a bridge for transplantation. So while these patients are waiting, they're on a transplant list, waiting list, for them to stay transplantable or being able to be transplanted, we do ablation as a bridge, or sometimes we downstage them. For example, they have multiple lesions or few lesions that they are outside the criteria for whatever criteria that specific center is using. For example, they're using Milan criteria, and this patient at the moment is outside that criteria. So to bring them to that criteria, we can also use ablation, and this is what we call it down staging. So generally we're using it for child Pu1 and 2 cirrhosis, and we are also using it for metastatic lesions. So we use it for metastatic breast, metastatic colorectal lesions, and the common ones that we're using are cryoablation, microwave ablation, radiofrequency, and electroporation. And also it's important to know that I personally use a lot of microwave ablation, and it's very effective in the liver. I tend to treat a lot of deep lesions and next to vessels, so I prefer to have less sink effect, and by this clearly less recurrence. As I also showed in evidence that microwave has upper hand over the radiofrequency, as in for less local progression and clearly faster ablation times, and this is especially true for larger lesions, say for example more than 2.5 centimeter lesions. So this is what we one of the tumors that I treated, one of the cases that I treated, so was this patient was in cirrhotic liver. As you can see, there was this lesion in the left liver. You can see a pseudocapsule. I ablated this. This is a follow-up. On the follow-up also more lesions seen. This is in segment 7 and one in the caudate lobe. I treated this one in the caudate and also this one anterolaterally in the segment 7. And I don't know whether it presents well. Also, this is the post-ablation change 2 months after that, and it was a complete response. The MRI 6 months after the last treatment. There's another lesion. This patient had a breast cancer. As you can see, there's a single tumor that I ablated with microwave, and this is 6-month follow-up. Again, shows complete response of the tumor ablation. So that will take me to, I've got 2 minutes, so I need to finish and wrap up quickly. And so as a general principle, local recurrence is very important in these cases. And these are the 3 studies by Hamada, Solbiati, and Hamel. They showed that local recurrence directly related to the size of the tumor. So for example, if it's less than 3 centimeter, it has a 14%. It was in that study. In 2012, it had a 14% risk of local recurrence on follow-up. By Hamel showed around 3%. However, if it's more than 5 centimeter, as in this one, or 3 to 5 centimeter, it reached up to 70% local recurrence. But in Hamel's one, it was around 27% local recurrence. So this is just to show that it's directly related to the tumor size. And that was also a study by Tanis and his group that showed in 2014 that showed recurrence per patient and recurrence per lesion for resection and chemo, both pre and post-operative chemo, versus radiofrequency ablation plus adjuvant chemotherapy. So recurrence per patient was more after the radiofrequency ablation, and significantly more recurrence per patient. And clearly this was because in case of surgery, sometimes you do segmentectomy or a complete resection of the right liver or the left liver. So clearly the recurrence per that patient will be less. However, recurrence per lesion, this is important to know, recurrence per lesion was around 6% for both radiofrequency and for the resection. And for less than 3 centimeter, it was around 2%. Again, so clearly I know I'm slightly above our time, but we use it for bone tumors. Especially, I use it a lot for for osteodyostoma. This was a case of osteodyostoma that I treated with radiofrequency ablation in the tibia, and this is a follow-up. 3 months after that, you can, with MRI, there's loss of disappearance, of the edema and complete cure of the osteodyostoma. So in summary, ablation is a well-established alternative to surgery tools that can be a very powerful interventional tool for our patients. Clearly it's effective, as I showed, safe, and allows for shorter recovery time. This is important, along the lines of less bleeding, less ICU stay, less infection, and all this. And clearly that transforming the treatment option available for our patients from limited 1 or 2 type of treatment to much more than that. And I appreciate such activities because that will lead to increased awareness among the medical professionals to be aware of this available treatment option for the patient. And thank you very much, and hopefully you guys benefited from the presentation. Thank you.
Okay, we'd like to thank Dr. Dilan for his presentation. Remember, this was a pre-recorded presentation.